any question, please type in the chat box, or you can leave it to us at the end of the presentation. Yeah. Dr. Alice, you can start your presentation now.
Okay, thank you. Can you hear me? Can you hear me?
Yes, we can hear you.
Okay.
I can hear you.
Okay, thank you for the nice introduction, Sile. And I should share my slide first. Okay.
Yes.
So can you see this?
Yes.
My slide. Okay.
Yes.
Just wait a moment. I think I cannot control that. Okay. Once again. If it's not good for me, I will try again. Sorry.
No problem.
Okay.
Yes, we are seeing your PowerPoint slides. Yes.
Okay, so I will start my talk today, and I'm honored to share some of my knowledge and experience.
This is not the slideshow mode yet. This is the layout on your PowerPoint only. It's not the slideshow mode.
Okay. Does it work? No?
I'm still seeing the PowerPoint layout.
Yeah, it seems that I cannot let it work because I share the window only.
Oh, I see. Can you maybe try to share the entire screen and you can.
Okay, I'll try and I'll make some adjustments. Okay.
Yes.
So, is it working now?
I see a blank screen.
Really? Okay. I'm sorry that.
No problem. No problem.
So how about now?
I'm seeing your screen with a lot of Google Meet mirror images.
Yeah, it looks like this.
Okay. You can share your entire screen and then.
Yeah, now I will share the entire screen. And what am I going to do next? Here.
And you open the PowerPoint.
Where is PowerPoint? Okay. Can you see it now? So what am I going to do now?
Okay.
So, it's fine. I just use the layout mode.
Yes, I think can. So then you maximize the view area of the PowerPoint. Yes.
Okay.
Yep. Okay, we are seeing your slides now.
Okay, then I will start from here.
Okay.
Sorry for this.
No problem.
Okay. Now then I cannot control my mouse. What am I going to do now?
Hi, good morning. Maybe at least good morning. I'm Hsiang-Yu. Maybe you have to go to your PowerPoint, and then you can control for your PowerPoint.
Okay, here. So.
Yes.
It work now?
You are still seeing the presenter mode.
Okay.
Maybe you unshare and then share the. Then you share the slide mode.
Share this. Now I unshare, and then I share the. No, it doesn't work.
It works. We can see the full screen.
Yeah.
When you put share now and you go entire screen, you just go to the PowerPoint and make it slideshow.
Okay. I'll call again. How about it right now?
Yes.
Yes.
Okay. Okay. So I'll start. Sorry for the delay. Okay. Let's just start it with the overview of epilepsy treatments. And as we know, when we diagnosed epilepsy, and we started from anti-seizure medication, and almost 70% of them can be treated by at least one or two anti-seizure medication, and the rest of the 30% of the patient will be fulfill the criteria of drug-resistant epilepsy. And they can divide into two ways. Some are surgically remediable, and the others, they cannot be submitted to surgery. So what are we going to do next? For those who are surgical candidates, we can go to the surgery, and they have a high chance to become seizure-free after surgery. But for those who failed after surgery or not surgically remediable epilepsy, we can try the third or the fourth drugs, and we still have a 15% of chance to become seizure-free. And if all these methods don't work, what are we going to do? They can try other alternative treatment like VNS, DBS, ketogenic diet, or CBD. And let's go to the surgical intervention for epilepsy. And as we know, epilepsy surgery are the best solution for patients who are candidates for epilepsy surgery. If they were kept in medical treatments, the chance to be seizure-free are much lower compared to those who undergo epilepsy surgery. And these two studies, one is for adults and the other is for the children. The evidence told me that we should try our best to help them to become seizure-free by the method of epilepsy surgery. And who are the surgically remediable cases? One, the pathologies are understood, and the natural history is reasonably well known, and they will be medically refractory or even progressive. And the pre-surgical evaluation should be accomplished non-invasively in the beginning. Most of them, we hope they don't have to go into the invasive EEG study. And also in those cases who we can expect the surgery can offer excellent chance, more than 60% or greater. And all these cases are good candidates for surgical treatment. And these are the some examples for those who can benefit well after epilepsy surgery. For example, unilateral mesial temporal lobe epilepsy, especially those with hippocampal sclerosis, they have a very high chance to become seizure-free after resective surgery. And also the lesional focal epilepsy caused by discrete structural lesion, like this one in lateral temporal region. And also in some cases, they have catastrophic unilateral or secondary generalized epilepsies. And we can try to remove, even it is so large, like hemispherectomy or large lobectomy, to get them out of, become seizure-free. And how about the outcome of epilepsy surgery? It's really work. And let's see that for temporal lobe epilepsy, especially mesial temporal lobe epilepsy, and 1 year after surgery, more than 50%. In some centers, we can reach 84% of them became seizure-free. And for localized neocortical epilepsy, the seizure-free rate can range from 40 to 70. And for those who are undergoing the big surgery like hemispherotomy, the chance to be seizure-free is still very high, 40 to 80. And for those who don't have any lesion, we call it MRI negative temporal lobe epilepsy, the seizure-free rate is still very high, around 40 to 60%. If we have a very detailed and delicate pre-surgical evaluation, they can get a long-term outcome. And here I would like to share our seizure outcomes of resective surgery. And we usually follow 2 years after resective surgery. And here we have, in past 30 years, we have more than 700 cases of resective surgery for epilepsy. And as you can see, we have 64% of them became seizure-free or only rare seizures 2 years after surgery. And if we put those rare seizures and, I'm sorry, that's 1A is aura, and 1A is totally seizure-free without aura. 1B is with some aura. So if you define seizure-free to a very strict definition, the seizure-free rate will be only 64. And if we include angle class 1 and 2 to be the good seizure outcome, there will be 84% of them became seizure-free. And about the pre-surgical evaluation, and here, this is a simple scheme of the pre-surgical evaluation. It's not so complicated. We just look at our dark green box here. We just need a high-resolution MRI, video EEG, and neuropsychological assessment. These three are very essential. And for better localization, we can add some functional or quantified method to localize our epileptogenic zone. And you can also use PETs like we did in Taipei Veterans General Hospital. The FDG PET is routinely used in our pre-surgical evaluation. And also you can do some functional assessment by the neuroimaging to lower the risk of postoperative deficits. And all this pre-surgical evaluation can be summarized in a multidisciplinary discussion conference. And to don't make any decision by yourself. I think teamwork can make it better. So after the team discussion, then you can, if you have a very good epileptogenic zone hypothesis, then you can submit it to patient for epilepsy surgery. If the conclusion is not very concordant among different examinations, and we need to confirm our hypothesis, we need to use the intracranial EEG. We call it phase 2. And all these, if they are not suitable for resective surgery or ablation, then we can try other methods. For example, neuromodulation. And I will spend more time here because all the intervention of resective surgery and the neuromodulation, the pre-surgical evaluation are almost the same. And neuromodulation is less invasive, but they still need a very comprehensive pre-surgical evaluation. And the surgical treatment for drug-resistant epilepsy included resective. The ATL, anterior temporal lobectomy, are most common and has a long history. The outcome we know is quite well, around 60 to 80% of seizure-free after surgery. And then we can also minimize the resection by selective and amygdalohippocantectomy. And the approach can be transsylvian or supracerebellar tentorial approach, and that will minimize the wound of our craniotomy. And also extratemporal. For disconnection surgery, we can do callosotomy, functional hemispherotomy, multiple subpia transection, hippocampal transection. And this is still this disconnection procedure still need a big craniotomy to do the procedures. And it is a trend for all the surgical field going to the minimally invasive surgery. And neuroablation is one of the derivative. We can use radiofrequency thermocoagulation, gamma knife, laser ablation, or MR-guided focused ultrasound. And at the end, the palliative treatment, neuromodulation, I put here into the surgical treatment because they are invasive. We need to send the patient to the OR, anesthetize them, and put the device into their body. So it's still surgical procedures. And let's talk about neuromodulation for epilepsy. And there are two types. One is invasive. Invasive, I told we have to implant. We have cut the skin and put the device into the patient's body. So there is vagus nerve stimulation and deep brain stimulation or responsive neurostimulation. And for non-invasive neuromodulation for epilepsy, we can have transcutaneous VNS and transcutaneous trigeminal nerve stimulation. And also, this is trigeminal nerve stimulation. And RTMS here, and TDCS, and focused ultrasound. For invasive, here I would like to talk about the invasive neuromodulation because they are approved by FDA and CE, and the other non-invasive, and Silly, can I ask, am I still working? Can you hear my voice now?
Yes, we can.
Oh, okay, just because I can only see the screen, I'm not sure if I'm connected or not. Okay. So the invasive neuromodulation here, they are approved since 1994 and DBS in 2010, in CE, RNS in 2013 or 14. And this is the illustration of how they implanted. VNS usually were implanted in left side. We don't have to go into the brain, so it's relatively non-invasive. And we have to implant the IPG here in the anterior chest. And also the DBS before in the earlier time, the IPG for DBS cannot use bilaterally. So if you have some patient who had implantation of DBS maybe earlier than 2010, we will see bilaterally implanted electrode with 2 IPG in the test. But the new type of the IPG now, one IPG can have can control 2 electrode, and it can adjust the setting or the stimulation at different setting bilaterally. And also the responsive neurostimulation, they have to put the stimulation and the detection electrode inside the brain, and there is the IPG was buried in the skull here. So there is no IPG going to the anterior chest wall. And how can they work? It's just a simply illustration showing the different network involved in these 3 different neuromodulation. This is the anterior thalamus nucleus, DBS. The network modulated and involved in this stimulation, including puppet circuits and the anterior nucleus of thalamus, also the mammillary body and the hippocampus. So if you put the DBS in the anterior thalamus nucleus, then this is the network which are activated. And it's more complicated for VNS because the vagus nerve was stimulated first, and the signal going back to mainly the tractus solitarius and all other brainstem nucleus. And they can activate some neurotransmitter like adrenergic, cholinergic, serotonic neuron to modulate the brain environments. And then they project it to the amygdala, hypothalamus, and even hippocampus or insular cortex. For RNS, it's quite simple. You just stimulate the epileptogenic zone, and you detect something, and you stimulate the epileptogenic zone or the hub that can trigger the seizures. So it's quite simple, more target to the epileptogenic zone rather than neuromodulate a widespread network. And this is a simple review of all these 3 devices, how good they work in seizure reduction. And this is a VNS. And I just introduced the DBS for anterior thalamus nucleus. Actually, you can stimulate any part in the brain. If you think that part is a very important hub or point or zone to start or to modulate the brain network in this patient, they can be used. But mainly is anterior thalamus nucleus. And there are some small case series, they stimulate bilateral hippocampus. And recently, the central median nucleus of thalamus is a hot topic for generalized epilepsy, especially secondary generalized epilepsy like Lennox-Gastaut. The stimulation in this area can produce a good seizure outcome, and also RNS. And let's see the VNS in the randomized trial. In the early trial, they will evaluate the effects at 3 months after stimulation. And we can see only 15 to 28% seizure reduction. But after the open label phase, a long-term outcome, we can see more than 60% of the patient have more than 50% of seizure reduction. And for all the 3 locations after deep brain stimulation, the seizure reduction in the beginning seems better and quicker than the VNS. And they also have better seizure reduction in the open label phase, more than 50%. And for the central median, because the case are different from the other VNS and DBS ATN, so the outcome seems better, but they are usually the secondary generalized tonic-tonic myoclonic absence seizures. And for RNS, the outcome, because DBS and RNS are investigated much later than VNS, so the follow-up, usually the outcome was, we got the outcome prospectively. And for the VNS is approved before 2000, so some of the data are collected retrospectively. So we have to see they are not head-to-head comparison, but we just keep in mind the basic comparison, the basic background are different. And can they be seizure-free only by the neuromodulation? Yes, they can, but the percentage is not as high as resective surgery, no more than 50. It cannot reach that high. For DBS ANT, there are 80% of them can remain at least 6 months seizure-free, and for RNS, 28%, and in VNS, 8% of them can reach a 6 months seizure-free rate. And for every treatment, even anti-seizure medication, you can have the some patients respond not so good, even worse after the treatment. So for the neuromodulation, they have the same situation. For VNS, there are 3 to 4% of them. You can encounter patient whose seizure became worse compared to before implantation, and DBS 3% and RNS 5 to 8%. And that's just to see the pivotal trial of VNS. In the beginning, we see the outcome 3 months after the stimulation. Only 31% or 23% have are responders. Here we call the 50% of seizure reduction compared to baseline. We define them as responders. So the percentage is not that high, but after the we collect the longer data. Here is 2,800 cases from 78 studies. I can see that 2 or 4 years after VNS therapy, there will be 8% of them can reach seizure freedom, and 50 to 60% of them can have 50% seizure reduction. So we need to wait and be patient to see the effect of the neuromodulation. And here is another international registry VNS therapy data from more than 5,000 cases from children and adults. Their physician evaluate the effect, including alertness, severity of positio states, frequency of seizure cluster, mood, verbal communication, and they have an improvement. And quality of life also improved in those who are responders. And for cost-effective, because VNS is a long-time treatment, so we can get more effective and more data and from the seizure outcome, and also we can analyze the cost-effective. And ER visits, there are 99% of decreased, and hospitalization also decreased. And the length of hospital stay also decreased, and outpatient visits, we can also have a decrease. And how about the complication and side effects? The side effect for this device, we have to focus on implantation and stimulation related. For implantation, it's very certain we can encounter some infection, but the rate is not so much because we don't have to go into the brain. We just have a subcutaneous superficial incision, so the infection can reach only 1 to 2%. And after implantation, sometimes we will have there will be some injury to the vocal to the vagus nerve and it will cause unilateral vocal cord paralysis. That's 1%, and most of them are most of them can recover maybe 1 or 2 weeks later. And for those who cannot recover, and we can inject some we call that something like collagen or something into the vocal cord, and the patient can speak as usual. And the side effect associated with stimulation, including the voice alteration, cough, dyspnea, and paresthesia, headache, and local pain. And usually you can see that when you change and you titrate the stimulation setting, the voice alteration will be immediately observed at your clinic. Also, if a patient have a sleep apnea, we have to be aware about the sleep apnea can be the condition can be worsening after the vagus nerve stimulation. But the newest type of VNS, we call it Sentiva, it has a function. You can stimulate at different amplitude or intensity in the daytime or nighttime. For those who have severe sleep apnea, you can reduce the intensity or even off the stimulation during the nighttime. And how about the anterior DBS? And this is the first trial that we call it center trial. The center trial study, initially there were 109 cases. They were divided into control and active. 1 month after the implantation, the stimulation was on. And here we can see the seizure reduction 3 months after the stimulation on was performed much better compared to those who are controlled. And for the long term, the center trial is a prospective study. So every 2 years or 5 years, they will publish their updated seizure control data. So the latest one, they show a 7-year follow-up. There are more than 74% of them are responders. And 80% have seizure-free period more than 6 months. DBS, you need to implant the electrode inside the brain. So just like we use in the DBS for Parkinson, they still have the infection issue or the hemorrhage issue, but usually are not so major. And after the stimulation on, we have to pay attention. That is really a side effect of depression and memory loss. For the center trial, there are 30% of them reported depression and 27% have memory problems. But this change will not be permanent. You can wait and adjust the stimulation setting. It can be controlled, or you plus some medication for the mood control. And also there's some stimulation-induced paresthesia. It is quite common. You can also lower the current. And also some cases will have a new seizure type, but only 3% have an increase in seizure frequency. Like VNS, the sleep cycle disruption can be also an issue, but not, this is influence the sleep cycle rather than influence the sleep apnea syndrome. And here we will consider the neuromodulation in who are the candidates for the neuromodulation. First, if they are not a good candidate for resection or ablation. For example, we identified the epileptogenic zone, and it was in the zone or the network was in their overlying eloquent cortex, or the epileptogenic zone are too widespread and multiple, or they are not able to be localized, and we cannot go to the resection. We can try neuromodulation. Or the clinical predictor of a poor surgical outcome, like for example, if the patient have a very high memory and cognition profile, and we notice that the seizure coming from the normally appear appearance hippocampus on the left side, it will be not a good candidate for resection for that patient. In this situation, we can consider neuromodulation. Or I don't like this reason. We have to try to devote it to show our confidence or the way to become seizure-free. But really, in the real world, some patients, they cannot accept craniotomy or to take some part of their brain for epilepsy cure. So VNS can be considered in symptomatic localized related epilepsy with multiple and bilateral independent foci, and also cryptogenic symptomatic generalized epilepsy, and the refractory idiopathic generalized epilepsy. And also, if your previous intracranial epilepsy surgery failed to control the seizure, you can try to use VNS. And some contraindication to do epilepsy surgery, like patients who have a bleeding tendency, they cannot tolerate long-term craniotomy, then we can try VNS. The time for surgery just 2 or 3 hours. And this is a suggested algorithm, which neuromodulation should be selected. And let's go here. We have to keep in mind the VNS for kids, for the patient younger than 18 years old, the VNS is the only approval for this age group. But we can, in some research or published data, we can see also some pediatric DBS or RS, I never seen that, but some young teenagers, they underwent DBS implantation. In this situation, that it is off-label use. So for adults, we can try to see if they are only 1 or 2 foci, we can try to do resection. Because honest, you have to localize the epileptogenic sites. So even the bilateral temporal lobe foci, you can try RNS. So if the epileptogenic foci is just 1 or 2, you can consider resection. And if not good candidate for resection, RNS is an option. And you can also try to use DBS VNS, depends on the availability in your country. And if they are more than 2 foci or fully localized, then we can try VNS, DBS, and RNS. And there, for VNS, they usually, if the epileptogenic network are more widespread and most are posterior focus, I prefer choosing VNS because it can modulate the posterior foci. But if the seizure onset is more like frontal temporal, as we illustrated before, the DBS anterior thalamus nucleus, they modulate the puppet circuit. So for frontal temporal focus, maybe DBS can work well, work better than VNS. But there is no strong evidence. It's just a hypothesis, but it's reasonable. It's feasible to think to decide the VNS or DBS based on this hypothesis. So if they are non-responder, you can shift from VNS to DBS or from DBS to RNS. We have some cases, they have DBS, then the battery running out, we change to VNS. And recently, there is a small research talking about double neuromodulation. They use VNS plus DBS, use 2 simulation together to make a better control for those who are really drug-resistant epilepsy. And care after implantation or programming. And for the VNS, you can just see how the LivaNova, they provide the table and the protocol. There is just a suggestion how to titrate your dosage of this stimulation. But usually we have better to wait for 2 weeks after the implantation because you need time to to let the electrode to fix well. And after the tissue reaction subsides, and the impedance will be more stable. At that time, you started stimulation, it will cause better control and the patient will feel better. And every 1 or 2 weeks, you have to adjust and see adjust the setting and see the response of the patients. And multiple, because the setting of VNS, it was from 0.25 to 0.125. So you can adjust to 0.25 in 1 day if the patient can tolerate. Today, I'm not going to go through too detail about the programming because time is limited. But in my experience, if the patient can tolerate, you titrate the setting the intensity output current as fast as you can, the efficacy will be better. And the phase 2, if you reach the target's amplitude and to 2.5 and the response is not so satisfactory, you can try to adjust duty cycle. And this is how we can adjust from 10 to 16 to 25. And the most one I use is 40 here, 41. But remember, because the new type of the closed loop, Sentiva or Aspire, they basically have extra stimulation by the auto stim. So the cycling, the duty cycle is basically higher than the original 103 or 102. So they don't suggest you titrate the duty cycle in this area. Just stop here. 35 is the uppermost. And initiation and titration of DBS. Clinically, my neurosurgeon turn on the stimulation just on the same day when patient was discharged. So you don't have to wait for 2 weeks or 4 weeks like a VNS, because the electrode is inside the brain, and it's practical to use the immediate stimulation after the implantation. The stimulation protocol, we usually started from 2 to 3, and you can adjust and increase the intensity. Don't go too fast. If you go to the 5 MA in the beginning, you have a high chance to increase the seizure and produce some bilateral tonic-clonic seizures. So like anti-seizure medication, you started at lower dose. And also the setting of the dosing in the DBS is much variable compared to VNS. VNS only one bipolar stimulation, but for the DBS, you can choose monopolar or bipolar. But monopolar can save the battery. Bipolar will make your battery running out faster compared to monopolar. And you can selection the electrode you want to stimulate based on your post-implantation imaging. And also, you can choose another stimulation site as your cathode. You can have 2 cathode or 3 cathode in the stimulation. You have to keep in mind the percept system and activa system, the way they deliver the outputs MA is different. For percept, each contact delivered the sets, but for activa system, it was divided by the number of cathode. So we have to be careful about this. And here we are going to talk about some safety issue. If you are not the initial, you are not the doctor in charge, you are not initiating or implant the device into the brain, but you will encounter some patients who have the VNS or DBS inside their brain, and they come to you, and you find you need to arrange an MRI for them. So what are you going to do? just be careful. You have to turn off them first. Don't just send them to the MR room because they will burn or heat the device. For the VNS, the body coil and head extremity, all this gray zone, you cannot arrange the MRI, the coil cannot cover this area. So there is some limitation for the VNS. But for DBS, you can change to MRI mode or turn it off. And there, the condition is not as strict like VNS. We can do some body coil and head or extremity, not like the VNS. But if you feel not so sure, you can just call the representative of the device company. They will give you some assistance. And let's talk the end. I will go through because time is limited. I want to leave some time for Q&A. The non-invasive brain stimulation include their advantage is low risk and cost effective. We can have the TVNS and TNS, and also repetitive TMS or TDCS. There is no incision and relative non-invasive. For TNS, we can see it. We can use bipolar transcutaneous VNS, just like VNS, but you don't have to implant the device into the brain, and the stimulation can be bilateral or unilateral. And some small studies show that it works for controlling seizure, but whatever, the tolerability is good. Only some local skin irritation, dizziness, autarkia, but the efficacy, we remain some more data to approve the efficacy. And like TNS, in 2015, the paper published, and some doctor want to try that, but in the past few years, there are no more obvious or evident data coming out. So it's still limited efficacy, but it's the tolerability is also good. RTM is the same, but here I like to share for status epileptics, there is a trial. They show efficacy, a small trial. So if you are in a very desperate condition for status epilepticus, you can refer this paper and see if it works. And for TDCS, you have to put the cathode stimulation to where you suppose the epileptogenic zone, and you can stimulate them. And also the evidence-based recommendation, they still need more data to support the efficacy. And here I took a new focus ultrasound. It's quite different from the previous introduced non-invasive study because they use the mechanical effect and thermal effect. For TMS or TDCS, they use magnetic or electric forces to modulate the brain activity. But for focus ultrasound, there is no radiation. They just use the ultrasound. So the mechanism is quite different from the previous device. But still, it is just an emerging study. We don't have any conclusive. But this year, the Brigham and Women Hospital, they publish their data, and they have 6 cases. You can see after the treatment, the seizure reduction seems quite stable, can last for at least 6 months. And here I'd like to share one of, I prepared 2 cases, but I just want to share that a patient, 24 years old, she has her first seizure at 10 years old, and the MRI was normal, the PET was normal, but the seizure was not well controlled. You can see even we use lamotrigine, perampanel, Briviact, the seizure has 47 every month. So it's quite disabling. And I arranged video EEG. She was talking here, and suddenly she became stare and motionless, remain very quiet. And she noticed this is a seizure. You can see the EEG is a typical 3 Hz by wave. So my diagnosis is idiopathic generalized epilepsy and mainly manifested by absence seizures. So I try to adjust the medication, use Depakine and use lacosamide, Sabril. Zonisamide works for a while but rebounds. And so she asked me to if I could use VNS implantation. So after implantation, you can see it has been more than 8 months. The seizure was well controlled, no more than 20 every month, every day. And she was very happy about this treatment. Just want to share, it's not commonly used in idiopathic generalized epilepsy, but in some cases they can benefit from the VNS stimulation. And this is just the 0.5, 0.75 is my amplitude. You can use just 1.5 can reach a very good control. And here I want to stop my talk here. This is the second case I just share about the DBS. So my take-home message is neuromodulation are effective alternative treatment for drug-resistant epilepsy. Curative treatment should be considered first. If they are good candidates for resective surgery, don't give up. And the responder rate for implanted device, you need to wait, and they will increase over time. And number and location of the epileptogenic foci and also the comorbidity are one of our consideration in choosing the device. And safety and battery saving need to be considered. And also the new non-invasive brain stimulation for epilepsy is potentially promising, but currently the strong data is still lacking. We need more data and more research to show their efficacy. And this is my talk today. Thank you.
Thank you, Dr. Alice. I think there are a lot of very useful informations in your talk. And especially, I actually think there is a slides on the algorithm for selection of the invasive neuromodulation technique. I think the flow chart is very useful for us to, put into clinical practice. I think we have about 106 attendees in the webinar. Anyone who has a question can either raise your hand, or if you want to type in the chat box, is okay as well. Why not I just start asking some question. So you mentioned about sleeping breathing disorders could be problems when it comes to patients who is going for vagal nerve stimulation. For those who looks like those having body habitus suggestive of things like obstructive sleep apnea, or those that have features like they snores very loudly at night, would you routinely do a sleep study for them first to see how bad was the breathing disorders in sleep before you enroll them for vagal nerve stimulation?
Yeah, it's a good question. I think if you have the resources to do the PSG to assess the severity of the severe apnea, you should do that first before your implantation. But it's not a contraindication for severe OSA to have VNS. You have to have the basic idea about the severity of the OSA before implantation. Then you can adjust your treatment or your setting after the implantation. It's not a contraindication, but you have to be careful about this. Because if the severity of OSA increased, the seizure control will be also very worse in my experience. Yeah, they go parallel. Yeah.
Okay, all right. Thank you. Anyone wants to ask any question?
Good morning, Dr. Wu. Hi, I'm Lechumi. I'm a technologist, EEG technologist in the lab. Do you, I have a basic question. Prior to putting in implants, VNS, do you have a checklist where you follow prior to putting the implant on the patient? A checklist to check any other medical conditions on the patient?
Yeah, I see. So if you see the manual from the VNS, as I remember, for some who had vagotomy, but I think I'm senior enough, but I haven't encountered any case who have vagotomy. But if your patient have vagotomy, they has only the other side, only one side of vagus nerve left, that you should not implant the VNS. And for other medical conditions, it just I don't remember I have any contraindication. But recently I'm going to implant the VNS to a case with hemophilia, but we are discussing if it is suitable for him to do that. Otherwise, I don't think we have any contraindication for them. But we have to be cautious about that. After the implantation, they can go to have some therapeutic ultrasound treatments or diathermy, anything that can increase the electric magnetic field that will interfere with the device. You should avoid that, or ask the patient to ask your doctor or the technician before they undergo the treatment. And also, if they have to go to the surgery, some electrocoagulant knife. When they are using that, we also have to be careful about the electrical magnetic influence on the device.
I see. Okay. Thank you. Now, why I raised this question, because in our lab we do intraoperative monitoring. If a patient has a device in them, for example, cardiac pacemakers, and the surgeon requests us to do transcranial MEP, we would discuss with the surgeon because whether it's contraindicated and to go ahead with the transcranial MEP procedure. So in relation to that, that's why I asked this question. If the patient has got a cardiac pacemaker on them, would you allow VNS to be placed on the patient?
I have no experience of this, but I remember there is some information in the manual of VNS. So for pacemaker, you have a pacemaker, then you want to implant a VNS. Basically, the patient who have a pacemaker for cardiac condition, their cardiac rhythm have a big problem with that. So I don't suggest to modulate or stimulate the vagus nerve to increase the possibility of cardiac arrhythmia or something. But I don't have any cases who had the device of pacemaker before we go to the VNS. They don't have that. But I do have patients who had the VNS and the DBS together to stimulate for epilepsy.
Thank you, Dr. Wu. Thank you.
Hi, I think Vinu just now raised your hands during the talk. Do you have any question to ask? If not, then we will see whether Derek also raised your hand right just now. Do you have any question to ask?
If not, then I'll ask important questions that I think many of us are interested to know as well. So because this is about selections and the cost of VNS and DBS are quite expensive in Malaysia. And that's why in the past, we used to ask, instead of just making it a palliative surgery, can we have some selections on patients who will benefit more with DBS and VNS? So for example, there are studies on predictive factors, positive and negative predictive factors. Can we use those predictive factors to select the group who are more likely to respond to VNS rather than most likely not responding to VNS? do you use any of these predictive factors or models?
Yeah, from the retrospective data from the VNS, because they have bigger database, but I think their predictor from different research are quite variable and not so very strongly evidence. But it says that Lennox-Gastaut syndrome, they have good response. And for the patient who have no structural lesion, the normal brain MRI, they work well. And for some research, they say adults respond better than children. But the other papers said that young children respond better than the adults. That's controversial. But for those who have Lennox-Gastaut syndrome or who has a normal brain MRI, I agree with them, but not very strong predictors. Because for all this needs to be implanted for this expensive device, all the patients, they are usually in a very poor control seizure condition. We are in a very desperate condition, and all these patients, their background and profile are so variable. It's hard to make any conclusion to build up the algorithm or predict model for them. But I think the AI and the machine learning is emerging, and we can get a lot of big data. Maybe the computer can help us build up a model. We put everything inside, and they can give us a chance or an answer about the successful rate, and to choose what it will be the best selection for the device.
Thank you.
I don't know if what's your opinion, Professor Lim? Yeah, I think in your experience, what will be the better candidate? What will be the good candidates for VNS or DBS?
Yeah, I mean, Lennox-Gastaut and some of the focal lesions is or non-focal seizures is good for VNS. But what we have encountered is that we have patients who are implanted and they pay for the device and the seizures didn't respond. So we have 1 or 2 patients with poor response to VNS and become a very tricky situations where the VNS is implanted, they pay the money, but the response is not good. So I was thinking if we can avoid or we can select the patient properly and avoid implanting patients with poorer outcome, then we may, avoid situations where the device is implanted without much effect.
Yeah,
so one of them is parietal lobe Wernicke area, seizure in the Wernicke area, which we cannot, mainly the angular gyrus and supramarginal gyrus, where we cannot do resections and we implant the VNS, but the VNS doesn't work at all.
Yeah, exactly. We are so we are so stressful for this kind of situation because the patient, they pay a lot for this device. Yes, we are still chasing for to increase our successful rate, but our medical is an art, and doctor has to accept some failure, but don't be frustrated. In that case, if I have the chance, I will try. If 2 years or 3 years the VNS don't work and the medication don't work, and maybe we can try DBS or the new emerging treatments. I think TDCS and the focused ultrasound will be very potential in the future. But here, I have to raise a caution to all of us here, audience here, for our ongoing focused ultrasound trial, and it will be not suitable for those who has implants in the brain. So, from in my own team, I will leave the DBS implantation to the end of the treatment, the selection. I will try focus ultrasound first. If they don't work, and then I will go to the DBS. Once you have DBS implanted in the brain, it's not suitable for them to do the focused ultrasound.
Right. Okay, thank you. Vinu, you have any question? Okay.
Yes.
Yes,
Maybe.
yes, please.
Just based on your algorithm, have you ever seen that in any of your patient that doesn't have it's lacking of seizure reduction using one of the neuromodulation, and then you go to another neuromodulation? What steps are you taking? Maybe someone is not response to DBS and then go to VNS. What is your criteria, and what your steps on choosing which neuromodulation? Do you have any experience of that?
Yeah, good question. For this device, we have in the real world, we have a background that they are expensive and they need to implant it. So you cannot just shift from one device to the other. So you want to change from VNS to DBS or DBS to VNS, it's not so commonly seen, just only in some occasion. But I did have some experience because the DBS was running out. And in Taiwan, the VNS, the government started to reimburse, to pay for the patient to implant VNS if their application was approved. We can implant the VNS and patient doesn't have to pay. So for my previous patients, if their DBS are running out, they cannot afford the battery replacement, then I have the chance to shift it to VNS. In my experience, I have two cases. The VNS implantation work better in their DBS. Yeah, the two cases, they like a VNS more than DBS. But only one case, the DBS work maybe just 25% better than VNS. And I have one very devastating poor control cases. She cannot talk well, and she has mentally retarded. She was now under both DBS on one side, the other is VNS. Because the DBS, the battery is running out, only 10 to 15% of battery left. We just implant VNS earlier. We did not take out the DBS from her body. We let it still going, and then we turn on the VNS. It seems to work better than the basic DBS treatment.
Very, very, very interesting experience. So you think that if someone is they have a good response in DBS, they are also good response in VNS, from your experience that on those two studies, on those two cases.
Yeah. In the beginning, the DBS work, they reduce the seizure. But when the battery is running out, we shift to VNS. We found the VNS work better than the DBS. But DBS did work in the beginning. Yeah.
Okay. Thank you, Vinu. Thank you, Dr. Alice. Okay, I think we just go on for the last question before we close. There is one question in the chat box says, may I ask any comments or experience of VNS implantation for super refractory status epilepticus secondary to Lennox-Gastaut syndrome?
Yeah, super refractory to Lennox-Gastaut syndrome. I have a case. He had epilepsy since childhood, but when he was 26, he suddenly had a super refractory status epilepticus. In that case, we implant DBS to the central median nucleus, and the seizure was partially, maybe just 30% reduction. but a long time, 1 year later, it seems better, but I don't know if it is coming from the effect of DBS or it's just a disease course, everything settled down. And in that case, I don't think, because at that time the VNS we need to pay. The patient have to pay. So in choosing the DBS and the VNS, I chose the DBS because if you implant DBS in the central median, there are some other effect like the so-called minimal conscious status. The alertness can improve and also can control seizures. So I choose DBS. Also, DBS can titrate very quickly to your goal setting, like 5 milliamp MA. But for VNS, even in status epilepticus, you still need to take several days and even weeks to titrate to the goal setting you want to do. So this is my experience, but not so much. I just also want to hear anyone who had experience to implant the VNS for the status or super refractory status epilepticus. Yeah, I read some papers. They works.
I mean, I don't have any experience using VNS in status though. Anyone in the audience that had this? Right. Okay, one last question. So we're going to close already. Right. May I ask whether you have access to RMS or TDCS in this case? This case, I suppose, is referring to the case with super refractory status, I guess. Is there any patient selection for TDCS or TMS?
Yeah, I don't have experience in this. I just use RTMS to study the motor evoked potential or brain excitability by RTMS. But one of my colleagues in Taiwan, she was doing TDCS clinical trial, and from the animal study to the human study, I think it is very potential, and the hypothesis and the clinical design are very feasible. So I think if I have chance to choose, I will try TDCS. And RTMS are safe for epilepsy patients, but clinically I encountered several cases who had recurred or outbreak seizures after the RTMS treatment for their spasticity or something. So I still feel a little bit concerned about the safety of RTMS, even though the society has claimed that it's safe for epilepsy.
Okay. All right. I think that's it for today, right? Thank you very much, Dr. Alice, for giving us the lecture and answering all our questions. Thank you for all the audience for attending the webinar as well. We hope to see you again, Dr. Alice. All right.
Thank you.
Bye.
Thank you, my honor. Thank you.
Thank you.
Thank you.